Well, let's start. Hello, everybody. I'm Sebastian Garcia Zamora from Argentina. I apologize for my mistake with the time for my opening speech. Fortunately, Professor Garcia saved me once again. Now we are going to talk about ECG in the acute coronary syndrome. In this session, I'm with a brilliant young cardiologist who also honors me with his friendship, Dr. Andres Miranda.
Thanks, Sebastian.
Let's start with the first presentation. Is Sevda Aygün between us? No.
He's not online yet. I don't see him online. I will have the second speaker, Dr. Ozan.
Ozan?
I'm here, Ozan.
Hi, Ozan.
I can
want to start
if you want.
Yes, great.
Okay. I'm trying to share my screen with you. Okay, can you see my screen?
Yes,
we can see.
Yeah.
Okay, I'm Ozan Tezen from Istanbul, Turkey. In this presentation, I will try to explain the value of ECG in non-ST segment elevated myocardial infarction. I will talk about red flags. First of all, we all know the definition of myocardial infarction, but very shortly, with a positive value of cardiac biomarker, one of these following symptoms, new ischemic ECG chains, development of pathological Q waves, imaging evidence, and evidence of intracoronary thrombus. Definition of ST segment elevated myocardial infarction is somehow easy. But what about non-ST segment elevated myocardial infarctions? For ECG, there could be transient ST segment elevation, persistent or transient ST segment depression, T wave changes, and even ECG may be normal. For the purpose of defining treatment options, European Society of Cardiology makes a classification. We classify these patients as very high risk, and low risk. For this presentation, I will emphasize these three things on my presentation: life-threatening arrhythmias, a very specific kind of ST segment changes, and dynamic changes. What is the purpose of classifying these patients? If a patient is at very high risk, we should choose an immediate invasive strategy. If a patient is a high-risk patient, we should use an early invasive strategy. And if a patient is classified as a low-risk patient, we can use a selective invasive strategy. The recommendation levels of these strategies are very high, and especially for early invasive strategy, the evidence level is also very high. I will use some patients to demonstrate what I want to say, but these following patients are hypothetical due to ethical, legal, and educational concerns. These are summarized and simplified versions of the most frequent scenarios we face as a very busy third-stage PCI facility. For the sake of timing, I must skip some of these, especially ventricular tachycardia patients with stable hemodynamic condition. As a life-threatening arrhythmia, this patient is clearly a very high-risk patient, and sometimes it's hard to classify or determine if a rhythm is really a ventricular tachycardia, but this is another presentation's topic. First scenario is that a 39-year-old male patient comes to an emergency service of a non-PCI health facility with chest pain, no risk factors, no formal medical records, And first ECG is like this. This is clearly an ST segment elevated anterior MI. With this ECG, physician of the emergency department immediately transfers this patient to a PCI center. But upon arriving to PCI center, as you can see, there is a normal ECG and chest pain is also relieved. In this scenario, this patient should be considered a high-risk patient and an early invasive approach should be chosen. Echocardiography is normal. Troponin levels are mildly positive. In this scenario, the most important mishap we face is that sometimes our colleagues from the primary health facilities forgot to send us the first initial ECG. In second scenario, same patient, but this time first ECG is normal because of ongoing chest pain and ECG follow-up was ordered, and fourth ECG is this time ST segment elevated. Immediately they transferred this patient to us. Again, when he came to us, chest pain is relieved and ST segment elevation is gone. This patient is also a high-risk patient. Again, same echo, same troponin levels. The most frequent mishap we face is that sometimes our colleagues overlook the ECG follow-up. And as you can see, there is a very, very tight proximal LAD lesion. If the chest pain is ongoing despite medical treatment, the patient should be considered as a very high risk and immediate invasive strategy should be chosen. It's clear. But if we overlook transient ST segment elevation, this patient can even be evaluated as a low-risk patient. And if we evaluate this patient as a low-risk patient, we may be very late to make an coronary intervention. And I want to emphasize that transient ST segment elevation is not a very high risk criterion. It's shown that transient ST segment elevation and relief of symptoms and immediate invasive strategy did not reduce MRI assessed infarct size compared to an early invasive strategy. These patients are not very high risk patients. They are high risk patients, and they should go to coronary angiography within the first day. Take-home message of these two scenarios is that every ECG of non-ST segment elevation myocardial infarction patients should be kept and evaluated carefully. Second red flag is that same patient 10 years later comes to an emergency service of a PCI-capable health facility with dizziness and vague chest pain. As we all know, 10 years ago, he underwent an LAD PCI, no other medical records. He is using an aspirin and metoprolol. First ECG is like this. This is a complete AV block ECG. Echocardiography shows that ejection fraction is 50% with reduced anterior wall movement. Blood work was sent. Temporary transvenous pacemaker was placed. Troponin levels were mildly positive. Do you classify this patient as a non-ST segment elevated myocardial infarction? Yes, we should. We have positive troponin levels, we have symptoms, and we should always remember that complete AV block is a life-threatening arrhythmia. And this patient is a very high-risk patient, and he should undergo to coronary angiography within 2 hours. And as you can see, this time, circumflex artery is like that. Sometimes we tend to overlook vague or mild symptoms, and we should always remember high-grade AV block is a life-threatening arrhythmia as much as ventricular tachycardia. So this patient is a very high-risk patient. Same patient, 20 years later, this time again with chest pain, 30 years ago LAD PCI, 20 years ago circumflex PCI. This time he also has hypertension and diabetes mellitus. He is using aspirin, metoprolol, perindopril, amlodipine, and metformin. First ECG is like that. This ECG described on this rectangular box is a very specific kind of ECG and highly associated with left main coronary artery disease. Ejection fraction is 35%, mildly positive troponin levels, moderate kidney disease, and this is the angiography of this patient. Also, this is a very high risk non-ST segment elevated myocardial infarction patient. ECG patterns associated with LAD proximal lesions, which are not mentioned either in European Society of Cardiology ST segment elevated or non-ST segment elevated myocardial infarction guidelines are De Winter pattern and Valence syndrome. De Winter's pattern is defined by Dr. De Winter in 2008 with his first 8 patients and highly associated with proximal LAD occlusion lesions. This is the original ECGs of first 8 patients. Valence syndrome is defined in 80s and has 2 types. In type A, biphasic T waves are seen, and in type B, inverted very deep T waves are seen. This syndrome is also associated with LAD proximal lesions. I want, after my presentation, a colleague of mine also will talk about this paradigm shift, but I want to emphasize that the treatment strategy of non-ST segment elevated myocardial infarction is apparently and enlargedly getting similar to ST segment elevated myocardial infarction treatment. Maybe these definitions are starting to get old. Thank you for listening to me. If you have any questions, I can try to answer.
Thank you so much, Ozan, for your presentation. I think we have some time for questions. So if someone has a question, is welcome. Or meanwhile, I would like to just remark one of your important messages is just all the ECGs need to be reviewed, especially when we receive transferals from other centers. It's very common that we only trust the ECG on admission, the ECG on the ED, and we usually missed those ECGs that were taken in the primary care context. So I think your message is very important, and again, we should encourage all our physicians to review all the ECGs. And the other aspect that was very important that you mentioned is the chest pain. I mean, the patient with non-STEMI and ongoing chest pain is always like a red flag, and we are always so focused in the echo, the high sensitivity troponin, waiting for the results of the new ECGs, and forgetting that the pain is also a red flag to be taken into account. So, would you like to highlight something about that?
I think chest pain, the clinical appearance of the patient is the most important aspect of primary care in those patients. If there is chest pain, we should be very fast to intervene.
Perfect. I see that Gary has raised his hand. So, hey, Gary.
Yes, thank you very much for the interesting talk. So I'm just wondering, in terms of the risk stratification for patients who have had NSTEMI, how would you stratify them in terms of arrhythmic risk? Is there any particular ECG markers that you think or you've seen to be quite prognostic with regard to the future arrhythmic events? Any prognostic indicators from the ECG?
As much as my own time with patients, if there is really a change in ECG, usually there is a lesion. But sometimes if the ECG is normal, sometimes these patients are perfectly normal. But I believe every change in the ECG is very important.
Okay. And with regard to the sort of culprit artery, so for example, if you go into the cath lab and you found some lesions that might not be related to the territory that you originally thought is implicated, would you treat the lesion as well?
This is a hot topic, but I believe only treating culprit lesion is better because these patients are actually not stable. We should first treat the emergent situation and then we will see.
Okay. Great, thanks.
I thank you.
Any other question? I have a question for all of you. What do you think are the most difficult ECG in the acute coronary syndrome, or the scenario when we most pitfall have?
Can I make a comment about this question? I believe that the last one I showed, the specific one with ABR elevation. This ECG is, if with a chest pain, a very high risk ECG. But sometimes if a patient is operated, we could also see this ECG. And sometimes it's very hard to classify those patients. If this is an really emergent ECG or it's just a chronic change. It's sometimes very hard.
Right. Andres?
I think just a quick comment is something that I've noticed in practice sometimes is that in patients with ACS, specifically in patients with STEMI, we usually miss a lot the rhythm disturbances, specifically AV block. That happens so commonly because, I mean, we have a patient coming to the ER with chest pain, diaphoretic, and hypotensive, and all the things. We take a ECG, and we are waiting for the ECG to be elevated in B1 to B4, and we see it, and then, oh, let's activate the cath lab, let's call everybody, and we got so excited with what we wanted to see, but sometimes we forget to check the P waves and just to check the rhythm. So that's something also I think I see challenging sometimes is the diagnosis of AB block in patients with STEMI, not because the diagnosis is difficult itself, it's because we usually just are only focusing in what we want to see, which is the ST segment elevation, and that's it. So that's challenging to my consideration too.
Great.
And may I have a comment?
Yes,
sure. Go ahead, Dr.
Yeah, and I think actually in terms of the non-STEMI patients, it's very important to immediately do echocardiogram because, you know, when we look at the occlusion and occlusive and non-occlusive MIs, sometimes you can see an occlusion with totally normal ECG. And that's why I think, but generally when you combine the ECG, the echo, the clinic, the chest pain, and then I think it decreases your, you know, to make your ratio to make an wrong diagnosis. So we should look at carefully the ECGs, the control ECGs, chest pain, and the echo is very important as well.
Yes, great. Fantastic tips. Andres?
Perfect. No, I think we're good. So maybe thank you so much for all, Ozan, for your presentation and all for the comments. I think we can go ahead with our next presentation. We have Elham Mahmoudi ready.
Hi, everyone.
Okay, so
Hi.
Yeah.
go ahead, Elham.
Do you have my voice? Is that okay?
We can hear you very well.
Yes.
Okay, I should share my screen. Okay, do you have my screen?
Yeah, we can see.
Yes. Okay.
We can see you.
Thanks everyone for their perfect presentations today. I'm going to talk about the localization of the culprit coronary lesions by use of the ECG changes. To talk about this and to understand how a specific occlusion in a specific coronary artery is going to change the ECG, the surface ECG, we should first know about the changes that we have in an ischemic in an ischemic myocardial in the cellular level. We all know these action potential and resting potential schematic figure, and we know that in the setting of ischemia, when a coronary lesion happens and we have lack of supply to some cardiomyocytes. The ischemic cardiomyocytes have some changes in their electrical potentials. Their potential during the diastole is less negative than the other cells, and their potentials during the systole, during the action potential, during the depolarization period is less positive actually. And we turn this to the extracellular potentials. We observe that the ischemic part of the myocardium becomes more positive and during the systole, and becomes more negative during diastole, and we have some currents of injury in this period. If we look at the heart from the view of the surface ECG leads that are adjacent to the ischemic portion, to the ischemic segment of the myocardium, we will see positive currents of injury. By positive, I mean currents of injury that are going toward the adjacent leads, and some currents of injury that are going away from the adjacent leads during the diastole, that we see them in the ECG, in the surface ECG, as depressions, downward shifts in the TQ segment and upward shifts in the ST segment. Taking these together, that means when we have inferior valve ischemia, inferior valve infarcts, we will see ST elevation in the inferior leads, in the leads adjacent to the infarcted section of the myocardium. Now we can talk in more details, and what we can extract from the ECG is much more than just saying that we have inferior ST elevation and we have inferior valve infarct artery. We can more accurate predict the more accurate location of the occlusions. How we can do that? First, we talk about the anterior valve myocardial infarction. When we have an anterior valve myocardial infarction, that means we probably have occlusions in the course of left anterior descending artery that supplies the anterior wall of myocardium, of ventricles. So that the left anterior descending artery has some branches, diagonal and septal branches, and if the occlusion happens after these branches, we only have infarcts in the anterior wall, and if we have infarcts, we have occlusions before these branches, we will have infarcts in their supplying in the diagonal branch and septal branch supplying tissues. What it means, the diagonal branch also supplies the mainly supplies the lateral wall of the left ventricle, and the septal branches mainly supply this interventricular septum, so that if our occlusion is before the first diagonal, the main diagonal branch, we will see a ST elevation in the lateral leads. One thing I should mention before this is that anterior wall MI shows in the ECG, presents in the ECG with at least 2 contagious leads of precordial leads, ST elevation. So if we have occlusion before the first diagonal branch, we will see at least 2 contagious precordial leads ST elevation, in addition to lateral leads ST elevation. Also, we will see, as you see in this ECG, inferior leads reciprocal ST depression, which is the mirror leads to the lateral, which is considered to the lateral ST elevations. If the occlusion is before the first septal branch, but after the first diagonal branch, we will see ST elevation in V1 in the right-sided leads, which are V1 and AVR in a standard surface ECG. And we will see probably ST depression in the lateral V5 and V6 precordial leads. These 2 samples are ECGs from occlusions between first diagonal and first septal, but not before both of these branches, because in some patients the first diagonal is the first branch, and in some patients first septal is the first branch. And if the occlusion happens before both of them at the origin of the left anterior descending artery, we will probably see both features, all features of the both occlusions, which means, for example, as in this ECG, we will have a ST elevation in 2 contagious precordial leads, at least 2 contagious, and also ST elevation in the V1 and ST depression in the V5 and V6, which are for occlusion of the septal branch. And we also have ST elevation in the lateral leads of 1 and AVL, which are mostly affected in high lateral MI by diagonal branch, and also reciprocal ST depression in the inferior leads. And if we have occlusion in the left main artery, which gives branch to the left anterior descending and left circumflex artery, we will have features relatively similar to the occlusion of the origin of the left anterior descending artery. But one point is prominent about left main coronary artery occlusion, which is some authors suggested that the ST elevation in AVR is more prominent than the ST elevation we observe in V1, which is which favors left main occlusion. But these are not accurate about left main occlusion, and some authors, for example, a cohort by a case study by Fiol et al. Suggested that if a left main artery has a total acute occlusion, we will see no ST elevation in neither in V1 nor in the AVR. So about the left main occlusion differentiating from origin of left anterior descending artery occlusion, data is not so accurate. If the occlusion of the left anterior descending artery is not before these main branches, and it's in the distal portion, mid to distal portion, after all the main dominant branches of diagonal and septal arteries, we only simply see just at least 2 precordial leads ST elevation, 2 contagious precordial leads ST elevation, as we talked about it in the anterior MI. What about inferior MI? Inferior myocardial infarction means infarction in the inferior wall of the myocardium, the ventricles. The important point about this type of myocardial infarction is that this part of the myocardium is supplied by the right coronary artery in the majority of the population, but it is also supplied or exclusively supplied by left circumflex artery in a minority of population. So if we want to differentiate, inferior myocardial infarction is caused by occlusion is each of these coronary arteries. We should mention some points. We have some clues actually. The right coronary artery have some other branches that supply the right ventricle, the right side of the heart, actually the right ventricle, which is the RV branches. So if an occlusion happens proximal to the RV branches, if an occlusion happens at the proximal portion of the right coronary artery, we will have inferior ST elevation for the inferior part of inferior wall of myocardium. In addition to that, we will have evidences of RVMI, right ventricular myocardial infarction, which we can see it here in the right-sided pericardial leads. Also, we can see some clues that are in favor of right ventricular MI, which is ST elevation in lead 3 is more prominent than lead 2, and also having ST depression in the lateral leads. These are all in favor of RVMI, concomitant RVMI, which are in favor of proximal right coronary artery occlusion. If we don't have evidence of right-sided MI, right RVMI, so how we can decide the occlusion? The occlusion is in the left circumflex artery or in the right coronary artery. There are also some clues. For example, the left circumflex artery is more probably associated with posterior infarctions, which in the standard ECG is presented by ST depression, significant ST depressions in the pericardial leads, and we can more accurately say that if we don't have these ST depressions, we more probably have occlusions in a dominant circumflex artery rather than having an occlusion in a distal portion of a dominant right coronary artery. As you can see, we have inferior ST elevations. The ST elevation is not more prominent in lead 3 than in lead 2, and we don't have ST depression in lateral leads. We don't have we have significant ST depressions in the right pericardial leads, which are in favor of a concomitant posterior MI, and is not in favor of right-sided MI. So we probably have occlusion in distal portion of the right coronary artery or in the course of left circumflex artery. What about multivessel involvements? If we have 2 or more occlusions in more coronary arteries, in more than one coronary arteries, in some cases we have features of both occlusions. For example, in this picture we have an occlusion in left circumflex artery and also in the right coronary artery. So we have a ST elevation in lead 3 more than lead 2. Also we have minor ST depression in the lateral leads. Also we have evidence of posterior infarctions, which are in favor of both occlusion of both RV branch, having no flow in the both RV branches, which are in favor of RCA occlusion, and in addition to an L6 left circumflex occlusion. But when in this other patient, we have an occlusion of left anterior descending artery with some faint collaterals, and also an occlusion of right coronary artery, we have evidence of inferior MI, but with ST elevation in lead 3 more than lead 2, and maybe evidence of right-sided infarcts, which we can't say because we don't have the right-sided pericardial leads. But we don't have a ST elevation in the anterior pericardial leads. We just have significant ST depressions in the V1 to V3, which are in favor of which may be due to a chronic occlusion of left anterior descending with some faint collaterals that may be be a cause for this, or maybe a cancellation of multiple currents of injury caused by an very extensive infarct in inferior, posterior, and anterior and lateral. So in case of multivessel occlusion, we can't definitely talk about the location of the occlusions. And finally, the references I have used to find the best ECGs to explain this, and thank you everyone for your patience and attention.
Thank you very much, Elham, for your great presentation. Sorry.
Go ahead, Seba, sorry.
No, thank you, Elham, for your great presentation. Elham, would you make some questions or comments? Emrah.
Actually, yeah, I can ask a question. Actually, Elham, first of all, thank you for that great presentation. Thank you, it was great. My question is, you know, sometimes, actually, today I'm on call and I just have a case, and I will ask a question about that case. It was a 55-year-old case, and ECG was a bit ST depression, but you can easily say this is normal, but it was three-vessel disease, RCA 99%, LAD diagonal bifurcation 99%, and circumflex as well. So sometimes in multivessel disease, you may have no ECG changes. So what do you think about this kind of patients? How we should interpret these patients, or what is the clues to don't miss the diagnosis of these patients?
Thank you for your question. First of all these criteria that I presented have a limited sensitivity and specificity to predict and diagnose. About 80% to 100% about the criteria I used. Second, we must use echocardiography and biomarkers, cardiac biomarkers, and all we have, and also the history taking, and we should take all of this together to decide about the patient. And unfortunately, the ECG is not going to tell us everything.
So when you look at the mechanism, do you think to, let's say, if you have the lesion in circumflex and LAD both, is it is it the circumflex lesion or LAD lesion have a value to depress the ECG findings of the other lesion? It's very common. I see the three-vessel disease. If it is very widely diseased and with no ECG changes, it's very or with not. For example, there are an occluded lesion as well, but no ST elevation.
One other thing that I forgot to mention and forgot to emphasize is that we of course should take a right-sided. Use the right-sided precordial leads and the posterior sided leads if we are in high suspicious of acute coronary syndromes. Maybe your concern is that, or maybe it's just the limitation of the ECG.
Yeah, right.
Yeah. Can you add anything?
Actually, to my opinion, I think the most important thing when you look at the ECG to not just evaluate the patient with the ECG findings, If you have chest pain and of course echocardiography findings, this is very important. So you should do the angio. And actually, Sebastian and Andreas, do we have time to discuss more, or we should pass to other presentation?
Yes,
Sure, no.
we have 15 minutes.
15 minutes, okay. So the other thing, for example, that I want to ask and raise concerns is when, let's say, you have two culprit lesions, you know, not total, but let's say 90%, but both looks culprit. How do you decide to you know, for intervention, how you decide to intervene the first one? So my clinical practice is generally I use ECG if, let's say, if it's an inferior elevation, or if in the ECG I think that circumflex is more likely than LAD, then I first treat the circumflex lesion. And I want to ask your you know, your clinical practice as well.
Yeah. At the first one, I didn't get your second question. I just got it.
My second question, can you hear me now?
Yeah, I think it's a challenge. It's a big challenge for interventionists to decide on this. But I want to say we should take everything together. The collaterals, the evidence of chronic total obstructions, occlusions such as the CTO lesions, and maybe the acute changes in the ECG, of course, are important things to consider. About the patient I presented, I myself think that the LAD lesion, the left anterior descending lesion, is a chronic lesion, and both the ECG and the angiography are in favor of this decision. Yeah.
May I add, my name is Dr. Yochai Birnbaum. I joined towards the end of the presentation. What is the time in Turkey? I think we had a problem with translation. What is the time now?
GMT? It is 2 hours. 2 hours. It's now. It's 6 o'clock, 6 p.m.
6 p.m. where?
Yeah,
in Turkey?
6 yeah, 6
well,
p.m.
because they say GMT +5, and which is, I am in Central Time, Texas, which is 5 hours different. So I just joined. I'm in problem with translation. So I have not, unfortunately, heard the presentation, but I want to make a comment. I think we are talking about non-STEMI. In non-STEMI, the assumption that there is ongoing ischemia is wrong. Most of the patients that we see with non-STEMI tell us that they had chest pain and the chain resolved, or in front of our eyes, suddenly they have more pain, and they are completely different things. Now, when we interpret the ECG later on, not bedside, we have no clue if the patient had severe chest pain or resolving symptoms, and therefore the studies cannot differentiate between post-ischemic changes, acute ischemic changes. So you were talking about a patient that have lesions, significant lesion in both arteries. You are assuming they have active ischemia from both arteries, which is most of the time not the case. So the angiographer see a completely different picture than the electrocardiographer that try to understand where the ischemia based on the ECG, and there are many things included, including cancellation of vectors if ischemia two opposing area occur simultaneously.
Mm-hmm.
Thank you so much.
Yeah, wise comment. Thank you.
I think we have on the audience Dr. Birnbaum. as a discussion. So, Dr. Birnbaum, if you want to have a comment or add any
I
question.
just made.
Yeah.
I just made.
Sorry.
I mean, this is what I said. There was a problem with translation. It seems that I missed the presentation, and I'm so sorry, because according to the schedule that I'm looking right now, the session should start in 8 minutes.
You just missed two presentations. Now we just have two, so we have the rest.
Okay.
So
yeah.
you don't miss all. That's fine. Thank you.
Okay. So.
Thank you, Dr. Birnbaum. Thank you so much. Sorry about that.
Thank you, everyone. Thank you.
So I think we have a few presentations as well, right?
We have
Yes.
another presentation here, and it's
Yes.
Dr. Meyers just logged in. So, Dr. Meyers, are you there?
Yes, can you hear me?
Yes, we can hear you. So this is going to be our last presentation of the session. Thank you, Dr. Meyers, for joining us. And then you can go ahead, and after your presentation, we are going to finish.
Okay, very good. Let me just get my presentation shared here.
Thank you so much, everybody, for the comments and participation.
Are you able to see my slide there?
Yeah.
Excellent.
Yes.
Yeah,
Right.
and we hear you very well.
Okay, very good. Thank you all for inviting me. I really appreciate it. This is one of my favorite topics to talk about. I have, it seems, only 10 minutes to argue that everything that we've been doing for the past 30 years could be done better, which is a very daunting challenge. But let's get started and let's talk about it. So this is what I call the Omi Manifesto. Well, I'll get right to my point here. STEMI is a failed paradigm. STEMI has failed to do its originally intended purpose. STEMI was created to identify patients with acute coronary occlusion causing myocardial infarction so that we can find them easily and do an intervention designed to do nothing other than open up an acutely occluded coronary artery. And STEMI has failed to do this accurately. And yet most of the world still operates under this false assumption that STEMI equals complete occlusion and needs emergent revascularization, whereas NSTEMI equals only partial occlusion and doesn't need emergent revascularization. When in reality, about 25% of our NSTEMI patients are found to have complete coronary occlusion on their delayed NSTEMI cath. And those NSTEMIs with missed occlusions or delayed occlusions have double the mortality of the NSTEMIs without occlusion. On the other hand, about the same percentage of our patients with our STEMI activations are false positives who don't even have a culprit and have only harm from the cath lab. And so over the past 25 years, as we've been noticing deaths and bad outcomes from patients with acute coronary occlusion who don't have STEMI criteria on the EKG, we have been trying to put individual band-aids on the STEMI concept. And we called these STEMI equivalents for a long time. And this list just keeps getting bigger and bigger because we keep finding more and more patterns of acute coronary occlusion. And as a result, the entire concept of the STEMI equivalent has collapsed into meaninglessness. When I talk to an interventionalist where I work, there is no mutual understanding of what a STEMI equivalent is, how we're going to agree on it, how we're going to find it, and what we're going to do with that patient. And so STEMI has failed to do its purpose. And now our best attempt to fix it, the STEMI equivalent idea, has also failed. So I think if we want to do better for our patients, then it's time for the next evolution of the MI paradigm. And our suggestion is called OMI, or occlusion MI. Acute coronary occlusion is what we're actually looking for when we look at that EKG, when we look at the patient and decide whether or not they need emergent reperfusion therapy. This is what determines whether that therapy has benefit, because that's all the therapy does is open up the acute coronary occlusion. So to understand how STEMI has failed and why we have to progress beyond it, I think we need to take a second to look how we got to this point in history. The last time we updated this paradigm was in the year 2000, when we went from Q-wave to STEMI, after what we learned in the reperfusion era, when we used thrombolytics and large-scale RCTs. That era was culminated with the 1994 FTT meta-analysis, with almost 60,000 patients in thrombolytics trials where we enrolled them based on high clinical suspicion of ACS and then randomized them to lytics versus placebo. Before any subgroup analysis was performed, without using the EKG, lytics already had mortality benefit in these patients with an NNT of 56 to save a life. Amazing. Next, they broke those 60,000 patients into 3 subgroups, those with elevation on their EKG, depression, or neither, which they called normal. And they realized that the ST elevation subgroup benefited even more than the original subgroup. And the other 2 subgroups actually had a non-significant mortality harm from receiving those thrombolytics. So what happened here? When we went from not using the EKG at all and just giving lytics to all patients with good story chest pain, when we changed to using the EKG using the STEMI paradigm, we did a better job at finding which patients had occlusions and benefited from lytics and which patients didn't and got harm from lytics. And that was a huge breakthrough in 1994 when cath wasn't readily available and nobody knew how to read an EKG better than elevation, depression, or neither. But as we've learned in the past 25 years, we can do much better than this. Many of our STEMI criteria patients are false positives and only get harm from the cath lab and lytics. And some patients with ST depression and otherwise normal seeming EKGs actually have acute coronary occlusion and would benefit from emergent reperfusion. But this is all the future. Sadly, this is not how the world works today. We are still stuck in the STEMI paradigm like we have been for the past 25 years. Now that we know how we got to this point, let's take a closer look at how and why the STEMI paradigm actually fails. I keep telling you we're missing 25% of our occlusions and our NSTEMIs that get delayed cath, and here's one of the reasons we know this. Kahn et al. In the European Heart Journal 2017 did a meta-analysis with 40,777 NSTEMI patients. They all get delayed cath as a part of their NSTEMI RCT, and a quarter of them still have TIMI 0 persistent occlusion on their delayed NSTEMI cath. Those NSTEMIs with the delayed total occlusions have double the mortality at every time point compared to the NSTEMIs who do not have missed occlusion. And of the ones who survive, at every time point they studied, they all do worse with their occlusion. So let's see an actual example. Here's a patient who came to me in my emergency department complaining of acute left shoulder pain after lifting a heavy box. Here's his EKG, and there's not any real significant ST elevations or depressions. Maybe there's a tiniest hint of elevation in 3, but there's no STEMI criteria and no significant elevation here. So what he does have is hyperacute T waves in a very, very large distribution. I was concerned for acute LAD occlusion. So I activated the cath lab, despite having to break the rules of STEMI equals activation of cath lab. So he goes to the cath lab and he has a full mid LAD occlusion, which is opened up successfully. So this is a patient with acute LAD occlusion that my US guidelines would tell me not to even look for emergently. If I instead used the best available RCT evidence, I would be told that this patient who has a quote normal EKG would get mortality harm from thrombolytics. Well, we all know this is not true. He's one of the patients who actually has acute coronary occlusion that I could find with something else other than ST elevation criteria, and he benefits from emergent reperfusion. In fact, he should benefit even more than the same patient with STEMI because hyperacute T waves are usually earlier in the sequence of acute coronary occlusion. And so with at least a quarter of occlusion MI not meeting STEMI criteria, suffering double mortality, and things like hyperacute T waves being a part of the puzzle that we can solve, then why can't most providers identify hyperacute T waves? Why has nobody studied them and defined them in the past 25 years of ubiquitous catheterization? If you ask me, it's all in the name. The name is the biggest part of the problem. The name ST elevation myocardial infarction makes us think that the ST segments are all that matter. It's the only thing in the whole name of the disease. So instead of learning the full sequence of EKG findings of occlusion and reperfusion, our minds are restricted to just knowing this, ST elevation and Q waves. That's all that is mainly taught in places other than conferences like this, right? And this is how people's minds work, because that's how the paradigm is named. That's the whole definition. By making you count millimeters, STEMI prevents you from ever learning that ST elevation is always proportional to its QRS complex, which explains how you can have 0.5 millimeters of diagnostic ST elevation and RCA occlusion in this patient, and 9 millimeters of totally healthy and normal, proportionally reasonable elevation in a patient with a left bundle with this big of an S wave. Because STEMI really only applies to a normal QRS complex, STEMI makes you think that occlusion can't be diagnosed in an abnormal QRS complex, explaining how this patient died, a middle-aged lady with a pacemaker who came into my hospital with acute chest pain, and no one could believe that this EKG could be diagnostic of her acute RCA occlusion, because nobody knows what to do with STEMI when you don't have a normal QRS complex. And I know that of course, the modified Scarbosa criteria is the best thing we have right now, but nobody believes in that right now because the paradigm is called STEMI. And so she died 16 hours later on the cath lab table after they found her RCA occlusion. Because posterior acute coronary occlusion produces ST depression maximal in V1 through V4, which is ST depression, not ST elevation, the word STEMI makes a lot of people actually unable to even understand the idea of posterior acute coronary occlusion. Here was a middle-aged gentleman who was walking his dog when he suddenly had chest pain. He came to my hospital with acute chest pain and this ST depression, which the emergency physician and the cardiologist both called NSTEMI. Of course, it's a posterior acute coronary occlusion. And when the patient had his delayed cath, here was his circumflex occlusion, which was opened up very late, and unfortunately the patient died of cardiogenic shock on day 7 of hospitalization. And maybe the most dangerous thing of all is that the word STEMI makes you think that acute coronary occlusion causing MI in humans is all about the EKG, as if this disease were defined by a test used to look for the disease. That's insane. And nothing else we do in medicine do we define the disease based on the test. So for these reasons and so many more, the name STEMI inspires us to fail at the reperfusion decision. And so the solution to this problem has to involve a new name, a name that fixes these problems I've laid out and reminds us what we're actually doing, what we're actually looking for. So we recommend the name OMI, or occlusion MI. OMI reminds you what you're actually looking for. You're not looking for millimeters on a piece of paper. You're looking for patients with acute coronary artery occlusions that need to be opened. OMI doesn't say anything about the ST segment. It doesn't brainwash you into thinking you can diagnose one of the most important events in all of medicine with millimeters. OMI doesn't say anything about the EKG at all, trying to remind you it's not about the EKG, it's about the pathology that's happening to the patient. So I'm suggesting that we go from the STEMI NSTEMI paradigm to OMI versus NOMI. And I realize this is a big suggestion. It took 30 years of research and a whole era called the reperfusion era to go from Q-wave to STEMI. And it's going to take a whole nother era to get past that. And that era, I think, should be called the occlusion reperfusion era. And I think we're already in that era. So here are the studies that have been published by many people, some of them me and some of them my colleagues, some of them your very own Emrah there in Turkey. And I'll show you a couple things that have happened in the past few years. So after we proposed this in 2018, we had a couple of publications in 2019 and 2020. And then in 2021, we saw a kind of an explosion of literature about OMI. We have this full page of publications about OMI, a lot of them by Emrah there, and a lot of them by myself. Another full page in 2021, another full page in 2021. And I'll show you a couple of these. I'll show you the ones that are written by people completely external to me. So here are 3 studies published last year about OMI that are by independent interventional cardiology groups. So this is an interventional cardiologist in Spain who published this in the IJC last year, acute coronary occlusion and non-STEMI. If you change the way you look at things, the things you look at change. Last year, in a Greek group of interventionalists published total coronary occlusion and non-ST elevation myocardial infarction, time to change our practice. And I think maybe the best one of last year was by this group of interventionalists in India who published in Circulation saying of occlusions, inclusions, and exclusions, time to reclassify infarctions. Is angiographic occlusion really the real question rather than ST elevation? And I wrote very well and concisely, so I really recommend checking this one out if you're looking for an external opinion other than mine. But my point is, I think we're already in the occlusion reperfusion era, albeit in the very beginning. And I hope that this will help us move past the STEMI paradigm to the OMI paradigm, where we can really focus on what we actually care about, which is finding the patients with acute coronary artery occlusion and opening that up so we can save their heart and save their lives. And that idea is what I call the Omi Manifesto. So thank you so much for listening to me. Appreciate it.
Wow, thank you, Dr. Meyers, for your great talk. I think there was no a better way to summarize all the previous talks and to finish the session. So I would like to give just the word for a quick comments because we are on a little bit of a delay. So Dr. Erdoğan, Dr. Birnbaum, quick comments for Dr. Meyers. Or...
Please go ahead. Actually, I will do a quick comment. Thank you. It was a great presentation, and I think the ECG is not enough. Don't give enough information in terms of occlusion MI and non-occlusion MI. And I am actually, I think in the next future the machine learning may have value in terms of because we have a lot of data in the ECG, but we just look at some data. It's it's not a deep data. So the machine learning maybe in the next future give us some more information in terms of the occlusion MI and non-occlusion MI, which is the most important term in this area. Thank you.
Thank you.
May I make a comment? To make things even more complicated, there can be non-STEMI in a patient with chronic occlusion of coronary arteries. He may have bad prognosis. There may be a classical case of acute occlusion of an epicardial artery, but the patient presents late with ECG showing minimal ST elevation or not ST elevation and T-wave inversion, kind of a Wellen sign. This is no longer ongoing ischemia. This guy may benefit from revascularization because of remodeling or preventing gray ischemia. So when we define occlusion myocardial infarction, we have to add occlusion myocardial infarction with ongoing ischemia. So in the group of the STEMI equivalent that I worked on some of the papers, and I had disagreements with some of the group members because it includes Wellen signs with not ongoing ischemia, for example. And as you mentioned, the STEMI concept came from this meta-analysis that retrospectively showed that thrombolytic therapy worked on people with ST elevation. In another level of subgroup analysis, it has never been shown to reduce mortality in patients with inferior ST elevation. But we lump them together because it sounds right. We are doing a lot of things because it sounds right, but there is no evidence to support it. And we have been in some, like lidocaine for STEMI, for patients with PVCs that is no longer used. Routine morphine that is problematic, and so forth. We don't know. It seems plausible that we should identify those with ongoing ischemia or those that if they will reocclude the artery, like left main pattern, it will be disastrous. So yes, the concept is right. It should need a little bit modified, and it was a great presentation. I enjoyed it.
Thank you very much. I appreciate it.
Well, I think thanks again, everybody, the organizing committee, Dr. Garcia, Zamora, the presenters, Dr. Tezen, Mahmoudi, Dr. Meyers, and of course to the discussants for your comments. I think that's the end of our session, and thank you so much for your great talks and presentations and comments. and we'll continue with the Congress. Thank you so much.
Thank you.
Thank you so much, everyone. Sorry, can I just make an announcement that the link for the 4th session I've posted in the chat, so you can leave the session and join the next one if you're free. Thank you very much.